Very good evening. Namaste. I am Dr S Jayaraman. I am a consultant pulmonologist. Welcome to this Chest Council of India every Thursday webinar. So before starting into the official thing, I want to share one screen here. Can you see my slide? Hi, good. Is it fine? Now can you see the screen? Yeah. I'll do that. Okay. Okay. Good evening, respected all the members who are login and leaders of CCI. There is one sad news. One of our CCI leader, Dr. Nitin Abhengar's mother, passed away in the morning. Mrs. Sasikala Yashwant Abhengar, at the age of 84 years. So, for her soul, rest in peace. We'll have a 1 minute silent prayer. I request everyone be 1 minute silent prayer. Start from now. Thank you. Welcome everybody. Greetings from Chest Council of India. Welcome to this Chest Council of India Thursday webinar. Every Thursday we are doing a different kind of topics throughout India and neighborhood countries also. They are watching our webinar. More than 5 years. This is the 6th year. So every Thursday we are doing a different kind of topic, different kind of series. So we had a COPD series. Now we have a lung cancer series. Today is the CCI lung cancer webinar series part 4. I welcome everyone. So I am Dr. S Jayaraman. I am the moderator of this today's webinar. I thank you, Chest Council of India, for this wonderful platform to disseminate knowledge across the world. So I thank our trustee chairman, Dr. N.S. Krishna sir, and Narayana Pratibha sir, and the National CCI President, Dr. Ashish Dubey sir, and Dr. Anil Maske, Secretary, National General Secretary of CCI, and Dr. Vijay Kumar Chetty, CCI Webinar Coordinator, and the pillars behind the Chest Council of India, 24/7, 365 days, they're working hard to show the different kind of presentation, different topic, different moderator, different kind of speaker. I thank Dr. Sivani Swami and Dr. Kirat and Dr. Ravi Doshi, Dr. Atri Gangopatyay, and a lot of leaders. So they are working hard, more than 5 years now, they're 6th year. So different kind of webinar. Thank you CCI team for the wonderful disseminating knowledge in this purpose. So today's webinar, already we had a 3 part of lung cancer webinar series. Today is the part 4, CCI lung cancer webinar series part 4. So lung cancer under the lens, pathology and precision in diagnostic. This is the today's topic of discussion. So we're going to have the 4 important highlighting points of this webinar. One is the classification of lung cancer, so accurately into non-small cell cancer and small cell cancer. and the key subtypes relevant for the treatment decisions is very, very important. And the second highlighting point is the interpret the molecular diagnostics landscape, including the EGFR, ALK, ROS, PD-L1, MET, CROSS, and the therapeutic implications. And third highlighting point is apply best practices for optimal tissue acquisition, preservation, and communication with the pathology teams. The fourth is the evaluate the role of liquid biopsy and navigate practical challenges such as turnaround times, test fatigue, and cost considerations. So we have star speakers and star panelists. So we have wonderful panelists here. The presentation start from the flow of the event will be there are two presentations, 10 to 12 minutes each. Then we'll have a panel discussion. I request all the delegates post your questions in the chat box. We'll address appropriately. So you all know lung cancer is very, very common among the cancers worldwide. You take the world scenario. Lung cancer is the #1 cancer in men. And in female, this is the second leading cause of mortality and morbidity. So such a common type. Sometimes it's very difficult to diagnose clinically. India, we are a high TB burden country. So one of the difficult, whether we're dealing with the TB or the malignancy. So pathology plays a major role. So clinical, radiological, and pathological role is a very, very important diagnosis. There's a lot of advancement happening each and every field. Pathology also, there is a vast field. There are day by day. So each diagnostic test, molecular testing is coming up very, very fastly. So today we are going to have the two kinds of lecture, and may I introduce the first speaker, Dr. Venkat Sampath V, MBBS, MD, DM, medical oncologist. He is a consultant, senior consultant, working in Apollo Hospitals, Jubilee Hills, senior consultant oncologist. So he has 11 years of experience in oncology, and he is very much interested in precision oncology, targeted therapy, immuno-oncology, solid and hematological malignancies, breast cancer, lung cancer, ovarian cancer, colon cancer, prostate and stomach cancer. So he has a very vast experience, and he finished a DM medical oncology from the SVIMS, Sri Venkateswara Institute of Medical Science, and MD radiation oncology at NIMS, and MBBS from the Community Medical College. So currently he is working in Apollo Hospital, Jubilee Hills, Hyderabad, and previously he was in Yashoda Hospital and assistant professor in SVIMS for 1 year. So he has a lot of research publications. I welcome Dr. Venkat Sampath for this prestigious webinar as a guest faculty. Welcome, Dr. Venkat Sampath.
Thank you, sir.
May I welcome our second speaker, panelist, Dr. Sharada Nagoti is a distinguished thoracic and lung transplant pathologist, world-renowned for her expertise cultivated through fellowship in pulmonary and transplant pathology at Mayo Clinic, Arizona, University of Washington Medical Center, Seattle, and Cleveland Clinic, Ohio. So, with a wealth of experience in NABH and NABL, accredited institutions including SRL Diagnostic, Fortis, Medanta, MGM Hospitals, etc., she is a seasoned professional in reporting all aspects of thoracic and lung transplant pathology. Dr. Sharada ma'am is a visionary founder of the Association of Thoracic Pathologists and has pioneered in a diagnostic pulmonary pathology web series, contributing significantly to the Indian pathology community. Her international recognition is evident through invitations as faculty in conferences, which include not only a pathology, but also pulmonology, thoracic surgery, and transplant conferences, showcasing her commitment to advancing knowledge in lung pathology globally. She is a national delegate for the Fresh Air series podcast and represents India among the estimated lung pathology experts worldwide. She is a committee member in several professional societies and has many publications in national and international journals to her credit. She is currently associated with the CPAT Referral Labs, Hyderabad, where she enjoys a busy consultation practice, signing out primary and second opinion thoracic consult from various places of India. Welcome, Dr. Sharada Nagoti ma'am, for this prestigious CCI webinar.
Thank you so much.
Now I welcome Dr. SK Toke. He is a senior consultant, pulmonologist and interventional pulmonologist, MBBS, DNB, FCCP, MBA, PGD, HS, and his intensivist also. He's a director at the Muktai Specialty Hospital and ICU in Pune, and visiting consultant in various hospitals in Pune. Welcome, Dr. Toke. Last but not the least, may I welcome Dr. Sanjay Sahay, Professor and Head of the Department of Respiratory Medicine, Rama Medical College and Research Center, Hapur, Uttar Pradesh. He has guided more than 20 MD theses and more than 30 publications in national and international journals. His area of interest is the interventional pulmonology, critical care, pleural, and the parenchymal diseases. Welcome, Dr. Sanjay Sahay, sir, for this prestigious Chest Council of India webinar. So with this, we'll move on to the presentation. So we have two presentations. So back to back, the first presentation from Dr. Venkat Sampath is going to present on the molecular biology and the series of this thing. So first talk mainly focused on the pulmonologist's guide to the molecular map of lung cancer, making genetic markers clinically actionable by Dr. Venkat Sampath. So medical oncology, followed by we have Dr. Sharada ma'am is going to present on beyond the biopsy, ensuring quality samples and faster results, practical tips to bridge pulmonology and pathology. So this is the two talk. May I hand over the mic to Dr. Venkat Sampath for his first talk. Over to Dr. Venkat Sampath.
Good evening, everybody. Thank you, Chest Council of India, for giving me this opportunity to talk today on molecular diagnostic landscape and their therapeutic implications in lung cancer. So as we all know that lung cancer is one of the most commonest cancers worldwide, and it is the highest prevalent lung cancer, is the highest prevalent, and also majority of the mortality both in men and women is attributed to lung cancer. So most of the primary cause for lung cancer is smoking, as we all know. However, non-smoking related lung cancer incidence is increasing, probably due to environmental exposure or occupational carcinogen exposure and vehicular and industrial pollution, etc. So on my part, I would be focusing on the molecular classification of lung cancer and its implications. So the lung cancer classification over the last 2 decades has transformed from single entity to the distinction between small cell and non-small cell lung carcinoma, which is further histologically subdivided into adeno, squamous, and large cell carcinoma. So in the current paradigm, lung adenocarcinoma comprises a multitude of molecular oncologic subsets that change both the prognosis and management of disease. So as you can see, in lung cancer, when we focus on the histological subtype, non-small cell lung carcinoma accounts to 85%, and the rest is due to small cell lung carcinoma. So in non-small cell lung carcinoma, the majority of the molecular mutation is in the EGFR. So almost to the range of 30%, and this is quite higher in Indian patients to the order of 40%. So again, EGFR mutations, there could be heterogeneity. Some of the patients may have EGFR exon 19 deletion, EGFR 21 L858R mutation, which are quite well targetable. Whereas in some patients, there could be EGFR exon 20 insertion mutations, which is usually not amenable to the routine TKIs which we use. However, the newer TKIs can be used in this setting. Then most of the patients have KRAS mutations, which account for about 29%, and in that again, KRAS G12C mutation is around 39%. That is 11.7% of all non-small cell lung carcinomas. So KRAS mutation is usually doesn't respond to any target therapy. However, KRAS G12C, this particular variant of KRAS mutation can be targeted with adagrasib and sotorasib, etc. So BRAF mutations account for 5.5% of patients. So these can be targeted by dabrafenib, trametinib, etc. Then MET mutations, MET amplification, MET X14 skip mutations, etc., which are also it's an inherent mutation which could cause intrinsic stimulation of proliferation and metastasis, etc. So MET targeted agents like capmatinib, tepatinib. Then there is also an antibody drug conjugate here, which is teclistamab vedotin. So in addition to this, HER2 mutations can be seen in 3.8 mutations, so 3.8%. So here also there is a drug called zogratinib, then mobicertinib, poisotinib, etc. Then red fusions, ROS1 fusion, ALK fusion account for 2.3, 1.9, and 4.4% respectively. So ALK fusion can be targeted with lorlatinib, alectinib, etc. Whereas ROS fusions are targeted by crizotinib. For red fusion, we use selpercatinib. Then other mutations like HRAS, NRAS, RAT1 mutations, NTRK are all negligible, which NTRK fusions are also targetable with entrectinib, latrectinib, etc. So depending on the mutation, we can target. So there are, however, certain mutations which could be pathogenic, but there are no targets available. So in such patients, and in those patients who don't have any mutations, that is around 40 to 50% of lung cancers, we now explore immunotherapy. So immunotherapy along with chemotherapy is useful in that particular set of patients. So what are all the target treatments available in lung cancer at our disposal now? So depending on mutation, if it is like EGFR, BRAF, KRAS, MET, EGFR, again, exon 20 insertion, EGFR T790, which is a resistant mutation which develops following first line of TKIs. Then there are fusions like red fusion, NTRK1, 2, 3 fusion, ALK fusion, ROS1 fusion. Then immune checkpoint blockers like PD1, PDL1 inhibitors, CTLA4 inhibitors. So they basically are signaling the T cells that we are not alien cells, or we are not cancer cells, we are normal cells. So basically they are lulling our immunity. So by blocking the PD1, PDL1 pathway and CTLA4 pathway, we expose the cancer cells to the immunity, the T cells and the killer cells. So then cell survival pathways like mTOR and MEK pathways, angiogenesis, that is VEGF or VEGF2 pathway, cell cycle, microtubules, and metabolism, that is dihydrofolate reductase, etc. So these are all the areas, all the various mechanisms which we can exploit to develop various targeted treatments in our armamentarium against lung cancer. So lung cancer is not one entity, depending on the type of mutation, and in case the mutation is not there, depending on immune profile or molecular profile, we try to tailor our treatment or personalize the treatment. So as we can see, it's not a single entity, it is heterogeneous depending on what kind of mutation exists. So when we see the treatment evolution over time in the last 20 decades, various drugs have been approved, starting from Elimta, that is pemetrexed in 2004, then bevacizumab, then erlotinib, which is EGFR TKI first generation, then Iressa or Geftinib in 2003, Abraxane or paclitaxel protein bound in 2005, then ipilimumab, which is CTLA4 targeted immunotherapy, Ervoy in 2011, then docetaxel and crizotinib. Crizotinib is the first generation ALK inhibitor. Then in 2014, we have VEGFR inhibitor, Cyramza or ramucirumab, ceritinib, that is also an ALK inhibitor, then pembrolizumab, nivolumab, which are the immune checkpoint blockers. Then Tecentriq or etolizumab, that is anti-PDL1 immunotherapy molecule in 2016. Then in 2013, again, afatinib, dabrafenib, trametinib, dabrafenib and trametinib in BRAF mutated lung cancers. Afatinib is a second generation TKI in EGFR mutant lung cancers. Then again, 2015, Tagrisso or osimertinib, which is the third generation TKI. Nesitumab or Portrazza. Then Alecensa or alectinib, which is also again used in ALK mutated non-small cell lung cancer. Then other formulas of docetaxel. Then in 2017, brigatinib, durvalumab, bevacizumab, monoclonal antibody, that is antibody drug conjugate of bevacizumab with AWWB, that is MVASI. Then dacometinib in 2018, which is also a EGFR targeted therapy. Semiplimab, which is an immunotherapy molecule, and lorlatinib. Again in 2020, Pemfexy, capmatinib, that is Tabrecta, selpercatinib in RET mutated non-small cell lung cancer, lurbinectedin, then pralsetinib in RET mutation, then again entrectinib in 2019, famtrastuzumab deruxtecan. So from 2019-20, we have evolution of antibody drug conjugates, mainly wherein we use the power of targeted therapy as well as the chemotherapy in form of a vehicle or a payload which is attached to the monoclonal antibody that delivers it to the tumor tissue. Then tepmedco or tepotinib, that is used in MET amplified or MET mutated lung cancers. Then trilacyclib, amivantamab, which is a bispecific antibody. That is, it targets both EGFR and MET, which is now combined with lorlatinib to treat EGFR mutated lung cancer in first line with this robust data in terms of improving PFS to beyond 2 years. Then sotorasib, which is again used mainly for EGFR 20 for KRAS mutations, and again mobocertinib for EGFR exon 20 insertions. Then bevacizumab monoclonal antibody alemcis in 22. Then bevacizumab again bevacizumab antibody drug conjugate Vexelmla. Then adagrasib or Crazati in 2022. So this, with this evolution, we would be seeing all the newer drugs. So each pathway is what I would like to illustrate. So EGFR and ALK are the majority targeted driving mutations. So EGFR, once the ligand binds to the EGFR receptor, then there is downstream signaling pathway which could activate RAS, RAF, MEK, ERK pathway, or PI3K, AKT, mTOR pathway, JAK-STAT pathway, etc., which all downstream signal the cell to divide and at a rapid pace, and there could be cell migration, there could be epithelial mesenchymal transition and metastasis and rapid proliferation. So ALK mutation also down the line, it gets receptor dimerization and autophosphorylation. Then further down the line, there is a downstream signaling pathway cascade which triggers this cell division. So again, BCL2 family and PARP-mediated process and cell death decisions. So apoptosis pathways through BCL2 family and BCL2, which can promote pro-apoptotic pathways like mitochondria, cytochrome C in mitochondria. There could be cytochrome C release and apoptosis formation, caspase activation, and linked to DNA damage and PARP cleavage. So this repair through PARP can be inhibited by PARP inhibitors, and BCL2 inhibitors also can be explored to promote apoptosis and cell killing. Then again, BRAF signaling pathway. So once the receptor tyrosine kinase is activated, RAS, RAF, MEK, ERK pathway triggers the cell division down the line. So BRAF can be targeted by BRAF, especially BRAF V600 mutation, which is the major BRAF mutation. So this can be targeted by dabrafenib, trametinib, and again MEK inhibitors can also be integrated. So which are still being explored as treatment option. Then cyclin-dependent pathway regulation of cell cycle. So basically in the cell cycle, cyclin C, cyclin D, when they bind to the CDK4/6 complex, they activate the retinoblastoma protein and cause the elongation 2 factor to transcription, and thereby promote various processes of cell replication and DNA replication. So this pathway can be blocked by various CDK4/6 inhibitors such as abemaciclib, ribociclib, etc. Then we have CTLA pathway. So basically T cells, when they are presented with the antigen presenting cell from the tumor, they engage with them and they are supposed to attack the tumor cell. But however, the CTLA4 pathway disengages the T cell, and it gives a signal that the cancer cell is not a cell to be attacked. So with anti-CTLA4 antibody, we are inhibiting the CTLA4 pathway, especially ipilimumab is one such example, and trametinib. So by blocking CTLA4, we are exposing the tumor cells to our T cells, so thereby causing cell death. Similarly, HER2, HER3 signal cascade. So basically, HER2 receptors, which are the epithelial membrane receptors, are when they bind to the ligand, there will be signal transduction downstream through HER2, HER3 dimerization or FGFR2 and MET pathway, and all of them again they converge onto RAS, RAF pathway or PI3K, AKT, mTOR pathway, then STAT pathway and PLC gamma pathway. So they all are necessary for cell survival, cell replication, proliferation, gene transcription, and cell migration. So we can target MET pathway by MET inhibitors, so capmatinib, tepatinib, etc. Then FGFR inhibitors are being explored, and HER2 inhibitors. Now we have HER2 inhibitors, especially this HER2 mutation is different from what we see in HER2 amplification in breast cancer. So this can be targeted by HER2 inhibitors like zogratinib, which is approved recently. So again, MEG signaling pathway, which through when the growth factors bind to the receptor tyrosine kinase and engage the RAS-RAF pathway and cause cell proliferation and cell transformation to EMT, that is epithelial mesenchymal transmission, and metastasis and all. So that pathway can be targeted. So similarly, Notch1 signaling is one such pathway which gets mutated in response to hypoxia, leading to hypoxia inducible factor 1 alpha. So this Notch pathway, patients having Notch mutation, they tend to respond well to immunotherapy. So this also can be targeted. Then again, PD1, PDL1 pathway, similar to CTLA4, again PD1, PDL1 engagement on the T cell and the antigen presenting cell inhibits the T cell to attack the cancer cell. So by blocking the PD1 with anti-PD-L1 antibody, we are allowing our T cells to infiltrate the tumor, that is tumor infiltrating leukocytes, which can target the tumor. So again, PIK3, AKT, mTOR pathway, there are PI3K inhibitors like alpelisib, then AKT inhibitors, capivasertib, etc., which all can be used. So again, hypoxia pathway through VEGFR and all. So we have anti-VEGFR antibodies like ramucirumab, bevacizumab, then antibody drug conjugates, wherein the antibody is bound to a chemotherapy. So with this, I would conclude. I thank you for this opportunity, and I would like to engage in the panel discussion for any further questions. Thank you. Good evening.
So that's a very wonderful talk, Dr. Venkat, and very good evening to all of you. And at the outset, I would like to thank CCI for giving me this wonderful opportunity. So the title of my talk is Beyond the Biopsy, Ensuring Quality Samples and Faster Results. So to ensure that the sample is of the optimal quality and to provide faster results, the pathologist should be aware of his or her role, and the pulmonologist should be aware of the expectations of the pathologist from him or her. So coming to the role of the pathologist, the role of the pathologist is not just the tumor diagnosis, but the pathologist should be able to go beyond the tissue diagnosis to provide significant prognostic and predictive information, which is essential for the clinician in proper treatment planning. So as we all know, approximately 70% of lung cancers present at an advanced stage, rendering surgical resections impossible. And these are diagnosed and staged by small samples. There are a lot of advanced minimally invasive techniques which have evolved recently to acquire tissue, especially in the field of interventional pulmonology, like cryobiopsies and all. The tumor tissue biopsy is the gold standard, with formalin-fixed, paraffin-embedded sample being the most common archival material for molecular testing. Hence, it is very critical to handle these samples appropriately. So the different that we pathologists receive in our labs include the small samples, the large samples, and the liquid biopsies. In the small samples, we have the histology samples like CT-guided percutaneous transthoracic biopsy, USG-guided transbronchial or endobronchial biopsy, and sometimes biopsy of the metastatic sites. And in the cytology samples, we have the CT-guided percutaneous transthoracic needle aspirate, the USG-guided transbronchial or endobronchial needle aspirates, FNA of metastatic sites, and exfoliative samples like bronchial brushings, bronchial washings, bowel samples, sputum, and fluid, body cavity fluids or effusions. And in the surgical lung samples, we have different specimens like pneumonectomies, lobectomies, sleeve lobectomies, wedge resection, segmentectomy, and en bloc resection. So coming to the specimen transfer to the lab, the sample has to be delivered to the pathology lab as quickly as possible in order to prevent autolysis of the sample. So if the sample gets autolyzed, then it might decrease the quality of immunohistochemistry and molecular analysis. And the specimen should be sent in adequate volume of 10% neutral buffer formalin. If suppose the sample is not quickly transferred, is not possible to transfer the sample quickly. For example, in case of emergency surgery in the night, then the specimen should be kept refrigerated at a temperature of 2 to 8 degrees centigrade and processed the next day as soon as possible. So coming to the TRF, that is the test request form, it should contain all the following information. The site of the specimen or the type of surgery has to be mentioned, the clinical diagnosis. If the previous biopsy or if a diagnosis is available, that has to be mentioned along with the radiology of PET staging findings like location of tumor, single or multiple tumors, lymph node status, adjacent lung findings like presence of ground glass opacities or second nodule. So all this information helps in providing the pathological stage of the tumor. And if the patient has undergone a prior chemoradiation or immunotherapy, then the history of that neoadjuvant therapy also has to be mentioned because it has an important implication in the grossing of the specimen as well as staging of the specimen. And if the pulmonologist has any other special query, even that also has to be mentioned in the TRF. Coming to the processing of the lung specimens, pathological evaluation small biopsy specimens. In order to optimize the tissue to the maximum, we follow the 2-block setting during crossing. So in this 2-block setting, what we do is half of the sample is placed in one block for diagnostic and predictive immunohistochemistry like ALK, ROS, and PD-L1, and the other half of the sample is placed in another block for molecular testing. For example, if we receive 4 cores, then 2 cores will go into one block for diagnostic and predictive analysis, and the other 2 will go to another block for molecular testing. So what are the goals of small specimens? The first and foremost goal is to establish a diagnosis. So once a diagnosis is established, then the tumor is subtyped into a small cell carcinoma, adenocarcinoma, squamous cell carcinoma using limited immunohistochemistry panel. So why I'm saying limited IHC panel is that if the pathologist puts a bunch of markers, then the tissue gets exhausted and it may not be enough for further molecular testing. So that is the reason why the guidelines have recommended using limited immunohistochemistry panel. And the final thing, the third thing is biomarker testing. So coming to the importance of tumor subtyping, if you look at this WHO Blue Book, that is WHO classification of thoracic tumors, the WHO has emphasized on the point that non-small cell lung carcinomas should be further classified into a now more specific type, like an adenocarcinoma, squamous, or small cell carcinoma, wherever possible. And if you look at this red box, it says that precise histological classification of lung cancer is essential because of the clinical need for tailoring systemic therapies according to histological subtype, as well as molecular or biomarker profiles. So this is probably the key statement for molecular testing in lung cancers. So multiple diagnostic analysis are performed. The first is the H&E stain to confirm and classify that it is a malignancy and to classify what type of malignancy it is. Suppose if we are not able to classify it on H&E stain, then we go for the limited immunohistochemistry subtyping and we subtype the tumor. We use TTF1 for adenocarcinomas, P40 for squamous cell carcinomas. And if the tumor shows neuroendocrine morphology, we use neuroendocrine markers like chromogranin, synaptophysin, and INSM1. And then if for all adenocarcinomas, adenosquamous, non-small cell carcinomas favor adeno and non-small cell carcinomas not otherwise specified, they all go for molecular testing to detect the driver mutations. So the sample has to be triaged not only for H&E and immunohistochemistry, but also for downstream molecular testing. Hence, it is very essential that the judicious use of the tissue is very much essential. Coming to the pathological evaluation of cytology samples, here I would like to talk about EBUS TBNA, that is endobronchial ultrasound guided transbronchial 5-needle aspiration. It is a novel, minimally invasive method to sample peribronchial masses using real-time guidance. Currently, for mediastinal lesions, EBUS with ROSE is preferred to more invasive mediastinoscopy and VATS biopsies for the diagnosis and staging of lung cancer because of the increased diagnostic yield of the technique. So what is ROSE? ROSE is rapid on-site evaluation. That is evaluation done rapidly and on-site, where it's a technique where an experienced cytopathologist or cytotechnician is present in the vicinity of the bronchoscopy procedure, that is in the bronchoscopy suite, and guides the intervention of pulmonologist or thoracic surgeon in real time and allows termination of sampling after the acquisition of sufficient material for both diagnosis as well as for ancillary testing. So this is the outflow of ROSE, workflow of ROSE. So as soon as we acquire the sample, the EBUS TBNA sample, the sample is expressed onto a clean labeled glass slide, and these slides, some of the slides are air dried and some of them are fixed in alcohol, and these air dried smears are stained by a rapid stain like this fit, and the alcohol fixed stain slides are stained by rapid stains like PATH stain and rapid H&E. And then after that, under the light microscope, the adequacy is assessed by the pathologist. If the sample is adequate, then a preliminary diagnosis is given by the pathologist. If the sample is not adequate, then the pathologist requests the pulmonologist for additional sample for diagnosis. If the diagnosis is established, then the pathologist, and if it is a carcinoma, then the pathologist requests the pulmonologist for additional material for ancillary testing. And this additional material either is collected either in saline or formalin or preservative-like cytolite solution, and this is subjected to cell block and cytospin. The cell block is used for immunohistochemistry material, and both the cell block and the cytospin can be used for molecular and cytogenetic testing. Suppose if a lymphoproliferative neoplasm is suspected, then additional material is sent for flow cytometric analysis. If the diagnosis is a granuloma, if the pathologist finds a granuloma, then the additional material is taken and it's subjected for microbiology testing. So this is how the workflow of rows happens. Coming to the pathological evaluation of large or resection specimens. So this is a lobectomy specimen which I am showing. We gross the sample. So this is the lobectomy specimen. First, externally, we examine for any abnormal areas, for any puckering, for any additional structures which are attached like ribs or presence of any chest wall structures. Then we see the bronchial margins. We take the margins, the bronchial margin and the vascular margin before slicing the sample. And after taking the margins, then in case of wedge biopsies, we take the parenchymal margin. So after taking the margins, we then slice the sample and then we try to identify the tumor, and we take sections from the tumor sections, proper tumor, along with the tumor with the adjacent parenchyma, tumor with the adjacent pleura. We also take sections from the abnormal looking areas and also normal looking lung parenchyma. So this is a picture showing the bronchial margin. A shaved margin is taken, and after the shaved margin is taken, we can see that there is a tumor. It is actually a carcinoid that is shown here. So this carcinoid is seen protruding out of the bronchial margin. Then what are the goals of surgical specimens? It is accurate reporting of specimens with special reference to prognostic factors which will have an impact on the clinical outcome. So all these parameters are given in the pathology report. Accurate morphological subtyping, the status of the resection margins, the bronchial, vascular, and parenchymal margins, the status of the pleura, the status of other organs if attached to specimen like ribs, chest wall structures, whether there is any infiltration of the tumor into these structures, the lymph node status, and the pathology TNM staging. In case of NATs, that is neoadjuvant therapy setting, a pathological response assessment is given, whether it is a major complete response or a complete response. So these are all the things which are mentioned in the pathology report. So that is the role of the pathologist. Now coming to the expectations from pulmonologists or from the thoracic surgeons, make sure that the specimen is put in fixative immediately. The recommended fixative is 10% neutral buffered formalin and not normal saline. Formalin should be of adequate amount, that is, the specimen must be fully submerged in the fixative solution. The container should be labeled properly. The lymph nodes of various stations have to be sent in separate containers with proper labeling. All relevant clinical and imaging details have to be mentioned in the test request form. And in case of bigger specimens, surgical specimens, please mark the lesion and place sutures for the margins in situations where it is difficult to identify the lesion or the margins. And in cases where the pathologist faces difficulty in orientation of the specimen, the pathologist requests the thoracic surgeons to be available to help them with proper orientation of the specimen. And when sending the sample for frozen section, any useful information on orientation of the specimen to the definite resection margins which are to be examined should be included. So now I'll present a small case scenario. Patient suspected of lung cancer clinically underwent a diagnostic biopsy, immunohistochemistry was performed, and a diagnosis was established as non-small cell lung carcinoma. Then the material was insufficient for molecular testing. So a repeat biopsy was done for molecular testing, and this time it is sent to another lab. But the purpose of that biopsy, of a repeat biopsy, was not communicated to the pathologist. So the pathologist is not aware of the diagnosis, that it has already been worked up. So again, the pathologist starts right from the basic H&E stain, immunohistochemistry. Again, the tissue gets exhausted and there is no tissue left for molecular biopsy, leading to frustration of both the clinician and the patient. So proper communication is very much essential. The pulmonologist should communicate to the pathologist the indication of the biopsy. And at the same time, the pathologist also should be equally responsible to talk to the pulmonologist, and the pathologist should be aware of why the biopsy has been performed. So finally, the take-home message: precise pathological reporting of the lung cancer specimens requires integration of clinical and radiological information with gross and microscopic pathology. Hence, proper communication between the pathologist, medical and surgical oncologist, pulmonologist, and the radiologist is very much essential. And multidisciplinary discussions and tumor boards play a very vital role in this aspect. and the pathologist should be made a part of these meetings. So with this, thank you so much. And I hand over the session to Dr. Jayaraman for further panel discussion.
Welcome, Namaste. We had two wonderful presentations by Dr. Venkat Sampath, the role of treatment modalities, treatment based on the type of cell and type of mutations, and we have a lot of targeted therapy, so biological therapy, immunological. There are plenty of treatment availability based on the cell and the mutations. So wonderful presentation, Dr. Venkat Sampath. And we had a beautiful presentation about the beyond pathology. There are a lot of immunohistochemical and the molecular testing in the histological specimen and cytological specimen to arrive at the proper diagnosis for the proper treatment modalities. So with that, we'll move on to the panel discussion. Before panel discussion, I want to have a small announcement about our CCI Con. This is a CCI Con, Chess Council of India Conference, annual conference. So CCI Con at Kolkata. So next Friday, Saturday, Sunday, 3 days conference. I welcome everyone take part in CCI Con Kolkata. So we have multidisciplinary, a lot of programs awaited. Welcome to join in this August 20. This CCI Con conference. The venue is the Hotel ITC Royal Bengal. I welcome everyone. Kindly register and to take part actively in our CCI Con, our public conference. So welcome to join. Welcome to you at Kolkata. Thank you very much. With that, we'll move on to the panel discussion. So wonderful. We have a pathologist, and we have an oncologist, and we have two pulmonologists. So we'll ask in between. I request all the delegates post your questions. So accordingly, we'll address. So we'll move on to the first question to our pulmonology, Dr. SK Toke. So Toke, one of our clinical presentation is the pleural effusion.
Yes, sir.
Case scenario like 46-year-old male smoker, diabetic, massive effusion with dry cough and all. So if you're seeing the clinically, radiologically, patient is a smoker. So in India, this is a high probability of TB as well as smoking history, malignancy also. So first diagnostic tool. So under image-guided pleural tapping. So what are the practical guidelines while sending the pleural fluid for cytology and cytoblock? What is your experiences? What is the guidelines recommendation for the pleural fluid cytology and cytoblock? Okay.
Yes, sir. Good evening. Good evening, one and all. And at the outset, very much thank you to CCI team, NH Krishna Anna, Dr. Atri, Dr. Vijay Chennamchetti, and CCI officials. And as a moderator, Dr. Jayaraman sir, to you also. Very much thank you. Thank you for this very good question, which is relevant to any pleural effusion we are going to tap. But as the today's topic is regarding our lung cancer, so for this purpose, if we are collecting the pleural fluid, this should be that quantity should not be less than 25 ml. It should be minimum 25 to 50 ml. It should be accumulated or collected in the sterile container, and it should be properly labeled along with the proper clinical history, as Dr. Sharada said. Regarding patients' history also we have to put in brief, and it should be sent to the laboratory within 2 hours of the collection. If the time is going to get delay, we have to refrigerate this sample. We have to keep it in refrigerator. We should not freeze this sample. We have to maintain the temperature at around 2 to 4 degrees centigrade, and that up to 72 hours we can store it to prevent the cell lysis or cell degradation for the good results. And when it goes to the lab, there should be proper sampling taken, and that should be labeled properly, and that should be prepared by slide preparation as well as cell block for the finding of the malignant cells. So that's all regarding this one, because a lot of time it will happen. We'll send around 5 to 10 ml of fluid for the diagnostic purpose, routine purpose. So if we are suspecting or pathologist is suspecting malignancy, that fluid will not be enough, and then we have to retap that patient, and that will be very much painful to such kind of procedure as far as patient is perspective. Thank you, sir.
Thank you, Toke. Wonderful explanations, guidelines, recommendations, very clear that 30 to 50 ml fluid for cytology and cytoblock is mandatory. So we have to send the specimen as early as possible to the laboratory. So good. So well said. And coming to Dr. Sanjay Sahay, sir. So regarding the liquid biopsy, so we do the bronchoscopy in a case of DPLD, diffuse parenchymal lung disease, of varied etiologies. Maybe TB, maybe CTD, maybe malignancy, lymphangiosis, carcinomatosis, and all. We do the bronchoalveolar lavage. Previous terminology, we call it as the liquid lung biopsy. So liquid lung biopsy is BAL, so older terminology. Now, I am asking the question to role of liquid biopsy in the diagnosis of lung cancer. Liquid biopsy. Over to Dr. Sanjay, sir.
Thank you, sir. Thank you, CCI, for giving this opportunity, and that's a well-established platform. Coming to my topic of this one, liquid lung biopsy. Earlier, whenever we are doing any investigations, bronchoscopy or thoracoscopy or even aspiration, it's an invasive procedure. But what happened? We are now going beyond that. Normally, what it has been observed that lung tissue, cancerous cells, they release certain tissues or certain cells in the body which are being trapped, and we can see that. So actually, the liquid lung biopsy is a non-invasive procedure. It's not an invasive procedure where we see the blood. Am I audible? No?
Audible, sir.
So it is a non-invasive procedure. Usually, biomarkers which are present, circulating biomarkers which are present, we trap that and then see that, get the information regarding the lung cancers from the liquid, whatever we get. These can be obtained from the blood, from the saliva, from the urine, sometimes from the sputum also. And there are different whenever a tissue or the cancer cells is present, they release their tumor cells in the bloodstreams. Sometimes the DNA of the tumor cells are also present. There are some certain new aspect is there, what we call it exosomes. These are the vesicles which are present in the blood cell, and we trap them. Apart from there, the new concept is of developing a tumor-educated platelets. So platelets, it has been observed that platelets of normal individuals and the platelets having platelet from a cancer cells, they have got some changes in their structural activities. So this one, tumor-educated platelets are the new way where we check for the RNA and then the process that and to find out whether what type of cancer cells are there, and that can go for EGFR, go for other markers, and after that we can identify those markers, and then accordingly we treat the patient. So this is important that these liquid biopsy now, it is helpful in the way that patient don't suppose sometimes the patient, once we have done the bronchoscope for the second bronchoscope, if the samples are not sufficient, they don't agree sometimes. So from this, by using these blood samples, we can identify those cells, and we can repeatedly do those samples by doing PCR and other methods. We can identify. So liquid biopsy is now coming up in a great way that it is less problematic for the patients, and it gives us a good lot of information as far as cancer cells are there, and so that we can treat and diagnose the patient early, and for a long period we can see the progress of the disease as well.
Thank you, Sanjay sir. Thank you, Sanjay sir, for a wonderful crisp and clarity explanation about the liquid biopsy. Liquid biopsy is a non-invasive test. We're not taking the sampling from the directly lung tumor at all. So circulating tumor cells from the main tumor in the blood or saliva or sputum or the pleural fluid. So we are going to do the testing in the thing to find out what kind of cells present. So circulating tumor cells, DNA, that and all. So with the advanced technologies, it's coming up very rapidly in all the diagnostic modalities very rapidly. So thank you, Sahay sir, for the wonderful answers. And we'll move on to Dr. Sharada ma'am, so renowned pathologist, thoracic pathologist in our on board. Madam, how do you approach a lung biopsy with a clinical suspicion of malignancy? Over to Sharada, ma'am.
Thank you, sir. And so whenever I get a sample of a lung biopsy with a clinical suspicion of malignancy or whatever lung biopsy, first and foremost, what I do is I check the label of the sample, whether it is matching with the clinical details which are provided in the PIFM. So after matching that, then we process the lung biopsy samples, and we follow certain protocols in order to optimize this lung biopsy sample, because these lung biopsy samples, lung cancer biopsy samples, are molecular priority samples. So then after processing, we first make the H&E slide, and we see that slide under a light microscope. So H&E, when we see, the first and foremost thing is whether it is really a malignant sample or malignancy, or whether it is a benign diagnosis. So if it is benign, then we classify it as benign, and then we see what type of benign disease is there in that sample. If it is malignancy, then we will further morphologically, we will see whether it is an epithelial malignancy or a non-epithelial malignancy, like a lymphoma, or sarcoma, or melanoma. Suppose if it is a non-epithelial malignancy, we do the relevant immunohistochemistry markers, and we further subtype into any of these. Like I've already said, lymphoma, sarcoma, melanoma. If it is an epithelial malignancy, what we do is we further subtype it into either small cell carcinoma or a non-small cell carcinoma or other types of epithelial malignancy. If it is a non-small cell carcinoma, then morphologically on the H&E stain itself, we try to subtype it further into adeno or squamous carcinoma. Suppose we are not able to do that, we are not able to characterize morphologically on H&E slide whether it is a adeno or a squamous, and if it is a polydifferentiated carcinoma, what we do is we then go ahead with the immunohistochemistry markers. So as I've already said, we use the guidelines recommend using a limited panel of immunohistochemistry markers to optimize the tissue, to preserve the tissue for molecular testing. So we use minimal IHC markers for adenocarcinoma. I use TTF1. For squamous cell carcinoma, I use P40. If TTF1 is positive, I classify it as adenocarcinoma. If P40 is positive, I classify it as squamous cell carcinoma. Suppose if the tumor is showing positivity for both the markers, but in different populations, then it is an adenosquamous carcinoma. And if both the IHC markers, TTF1 and P40, if they are negative, then again we say it as non-small cell lung carcinoma, not otherwise specified. So out of all these, adenocarcinomas, adenosquamous carcinomas, non-small cell carcinoma, not otherwise specified, all these categories, they go for molecular testing. So this is how we do. We pathologists go ahead when we get a lung biopsy with a clinical suspicion of malignancy.
Thank you, Sharada ma'am, for the wonderful crisp and clarity presentation, explanation for the, if you suspect a malignancy in the tumor tissue, you will do the H&E stain for the histopathological identifications, and based on the epithelial or non-epithelial cell type, we will proceed into the other testing to confirm what kind of a cell, whether adeno or squamous, adenosquamous, or other non-small cell, etc., by doing the other immunohistochemical IHC markers, etc. So well said. Thank you very much. I'll move on to our oncologist, Dr. Venkat Sampath. Regarding so what molecular testing would you order usually to identify the targetable mutations? Venkat.
Good evening, sir. Thank you, Jayaraman sir, for this wonderful webinar. Thank you, Jay sir, and thank you all Chest Council of India. So basically, whenever once I get the information from the pathologist that histopathology wise it is adeno or small cell or squamous, my idea is to know the targets to plan treatment, both in neoadjuvant setting as well as locally advanced or metastatic setting. So currently, I would ask for NGS comprehensive panel. So in NGS comprehensive panel, it is a traditional Sanger sequencing, wherein the DNA is fragmented, then both DNA and RNA fragments are amplified, and then a library is prepared, and that is then parallel sequencing is done, and we get to identify the mutation or variant annotation. So the information I need from molecular pathologist is what kind of mutation is there, and including whether it is a point mutation like EGFR, suppose EGFR exon L858R point mutation, or exon 19 deletion, that is in-frame deletions, or it could be an insertion mutation like exon 20. So depending on that, again, there are different kind of treatments. So similarly, ALK mutation fusions would be there. So I want NGS comprehensive panel. Traditionally, what we used to do, we used to ask for individual tests like EGFR mutation analysis by RT-PCR. Then if it is negative ALK, then if it is negative ROS, then BRAF. Then now we have NTRK, NRG, and other HER2, MET, RET, KRAS mutations, and all for which there are newer molecules available. So that sequentially asking would not help now, because the tissue is the issue here. So as Dr. Sahay sir has rightly said, circulating tumor cells and the liquid biopsy will also help, but I would want the solid tissue as well. So, but when I ask for NGS, probably because the same molecular pathologist would be doing both, and the cost is anyway expensive, like 40 to 60,000 for the NGS comprehensive panel. Simultaneously, if they do liquid biopsy and they analyze if that what mutation is there and all, we can track it down the line. So I want integrated information is what I would require. So thank you, sir.
Thank you, Venkat, for this wonderful. And nowadays we are all practicing in an era of precision medicine. So precision pathology, precision oncology, where to diagnose precisely, to treat precisely, to prevent unnecessary morbidity and mortality. So one size does not fit for all. So needs a proper evaluation, proper cell typing, and proper mutation typing, all important for the targeted therapies to have the very good results of the survival and better cure rate and other rates and all. Thank you, Venkat, for the wonderful presentations. So we'll move on to Dr. SK Toke. The question is, how does EGFR mutation changes management of adenocarcinoma of lung? You know well, adenocarcinoma is one of the common malignancy among the non-small cell cancers. So
Yes,
in female also we are seeing predominantly, and non-smoking individual also we are seeing predominantly the adenocarcinoma. How does the EGFR mutation changes the management of adenocarcinoma of lung?
actually, EGFR mutation is most common in non-small cell carcinomas, and that too in adenocarcinoma, which is around 25% of the adenocarcinomas will be positive for the EGFR. After testing with NGS, or you can go single gene testing for the EGFR. Management, how does management it change? Because newer therapies, targeted therapies like TKIs, those tyrosine kinase inhibitors, first generation, second generation, and third generation, they are available with us. They are directly attached to the EGFR mutant cells, and they block it, and further proceeding of the cancer, you can say invasion or multiplication of cells will be inhibited, and they will give good results with the single therapy. That too oral, we can give this. First generation was this zeptinib, then erlotinib, then third generation currently we are using osimertinib, and all these are given in single tablet twice or once a day. And patient has not to come frequently to the hospital. He has to not go to the healthcare associations to get the healthcare associated infection. That too also prevented by taking these oral medications at the home. And by giving this targeted therapy, there is better chance to recover from the tumor or recover from the lung cancers. So EGFR mutation therapy, targeted therapy, in this way it is acting, and nowadays everywhere it is use of this targeted therapy has gone up, and that is helping the cancer of the lung cancer patient a lot. That's it about EGFR mutation. Thank you, sir.
Thank you. Okay, so well said. So role of EGFR mutation, the management of adenocarcinoma. So we have to fix whether patient needs what kind of targeted treatment and all. Thank you. Over to Dr. Sanjay, sir. Sanjay Sahay. Can you throw some light on the driver mutations in lung cancer?
See, there are a lot of mutations now have been seen, and it is really helpful, as Dr. Venkat said. It is the cornerstone for treating the patients in a different way. So these are the genetic alterations, are the driver mutations, which are the genetic alternation which we see, and it helps in identification of the particular type of genetic changes which occurs in the cell. And that is how we can see the biology of the cancer cells. We can also see, identify the site and what type of target treatment we can provide to the patients, and also see how these mutants they help for the process, help in response for the to see the response of the treatment. So a lot of, as I said earlier, that a lot of driver mutations are seen both for the small cell and non-small cell cancers. In the non-small cell cancer, which has been studied widely than that of the small cell lung cancers, this EGFR mutations, KRAS mutations, ALK translocators, ROS1, BRF mutations, MET alternations, as it has been said, and RET rearrangement. There are RET rearrangement. These are a lot of mutations which has been seen. These mutations are now being targeted to identified by different methods to identify those mutants, and thus treatments are now targeted to those things. We provide specific treatment so that these mutants they causes a change in the protein or protein nature of the cells. It has to be halted, and so that cell growth and can be checked. And that is how we check the process and progress of the lung of any cancer, in fact, in the body. So the development and finding of these driver mutations are very important nowadays. And this is what the molecular biology is going from simple identifying of the cells to going at the molecular level. This is how the things are developed. And I think in the near future, we can get this mutant for each and every type of specific mutant for each and every type of cancer cells.
Thank you, Sanjay, for the wonderful explanation for the driver mutations. One of the role. So, if we want to start the specific treatment, targeted treatment, personalized treatment, so these type of driver mutations, apart from the cell type, is very important for the diagnostic and treatment modalities. Thank you very much. So, we'll move on to the Dr. Sharada ma'am regarding how do the clinical and imaging details provided in the test request form help the pathologist in signing out the report with the right diagnosis. So you several times, pathologists several times insist. So doctor, please write what is the clinical diagnosis, what's the radiological finding, what you suspect and all. Majority of the time we miss to write certain important things and say tumor tissue, endobronchial biopsy tissue for the histopathology examination will send. But the clinical and radiological correlation with the pathology is very, 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 very important. So what is your experience in that the test request form? How much it will help in the diagnosis arrival from pathology perspective? Yes, ma'am.
So the information, the clinical and radiological information is actually very much important for the pathologist, not only to give the right diagnosis, but also to give the correctly gross the specimen in case of resection specimens, and also to correctly give the pathological staging of the tumor. So this information, whatever I have shown in my presentation, in the TRF form, all those information, all those details have to be provided to the pathologist for all these, for the correct diagnosis, pathology, for the correct staging and for the correct grossing. So, for example, radiology, imaging details if we see. So what happens is, like when the resection specimens are sent to the, are fixed in formalin, there is shrinkage of the tissue and there is architectural distortion. So sometimes we pathologists will not be able to identify the location of the tumor. And when we have these seating findings, then when we have these imaging findings, then we can correlate the gross specimen with the image, with the CT image, and this can help us to identify the exact location of the tumor. And that is one point. Second thing is the location of after the location of the tumor, number of nodules, whether it is a single nodule or whether there are any presence of any satellite nodules. Sometimes the satellite nodules will be so small that in a shrunken tissue, it will be very difficult for a pathologist to identify. So again, CT helps us in that way to know whether it is a single nodule or whether there are multiple satellite nodules. Why this is important is the presence of satellite nodules upstages the tumor. So that is the reason the tumor stage goes up. From T1 to T3, the tumor stage grows up. So that is the reason why it is very much essential for the pathologist to identify if there is any satellite nodules. Then the PET-CT findings can help us with knowing whether it is a single tumor or whether it has already metastasized. So this is about imaging and clinical details, like especially if there is any previous diagnosis, or whether there is any FNA diagnosis that has to be provided to the pathologist so that we can correlate whether this diagnosis is matching with the previous diagnosis. And another thing is most important information if the patient has undergone a neoadjuvant chemotherapy. In that also should be, that information should be provided to the pathologist, because in case of resection specimens, the processing of resection specimens, the pathology staging of the resection specimens, it depends on, it's completely different from the other resection specimens where there is no neoadjuvant chemotherapy is not given. And another point is, if there is a neoadjuvant chemotherapy, there will be the specimen can show reactive atypia. Then sample can show reactive atypia, and this reactive atypia, many times it may mimic a malignancy. So if the information is provided, the pathologist is aware that the patient has already undergone neoadjuvant chemoirradiation, then it will prevent the pathologist to misdiagnose that as malignancy and to diagnose that as reactive atypia due to chemoirradiation. So these are all some of the reasons why these information, this clinical and radiology details must be provided to the pathologist, not only for right diagnosis, for proper grossing and proper staging of the tumor.
Thank you very much, madam. The test request form is very much important to correlate clinically, radiologically, pathologically to arrive at the diagnosis, whether is it rebiopsy specimen or what kind of thing. A lot of information, so easily you can narrow down your diagnosis and easily make the diagnosis, and will give the good results for the pathology for our clinicians. Thank you, Sharada ma'am. So move on to Dr. Venkat Sampath regarding the question: would you prefer NGS comprehensive panel over NGS heart panel? If so, why? Venkat sir.
Yes, sir. So as I already mentioned, NGS comprehensive panel is what I would prefer if there is no financial constraints and patient can afford and all. But India being a resource constrained setting, many times patients have financial issues. And the problem is that NGS panels are not being covered under insurance. So the patient has to pay from his pocket. So in such cases, at least a majority of the patients would benefit if they have financial issues with hotspot panel, where we ask only for a few required mutations which can be targeted, like EGFR mutation, as Dr. Toke has well mentioned, that if we can use first, second, as well third generation, and now we have antibody like bispecific antibodies like amivantamab, along with TKI lazertinib, which have increased significant survivals. So again, ALK, ROS, RAF, and all. So only few mutations which can be easily targeted, but that will cost below 10,000, unlike NGS comprehensive panel, which costs above 50,000 rupees and all. So in cost constraint setting, I would prefer NGS hotspot panel, whereas ideal thing to do is NGS comprehensive panel. So again, the tissue is issue. So that's why we have, our very good support from the pulmonologists who do excellent EBUS and biopsies and all. It's a very challenging situation, patient to patient. Many times what happens is getting the tissue becomes quite significant, and pathology also, they have to use little tissue to do IHC and keep maximum tissue for NGS. So these challenges have to be addressed.
Thank you. Tissue is the issue. So finance plays a major role in deciding what kind of a panel test, whether heart panel or comprehensive panel. So it depends upon the finance and other background. Yes, thank you. So we'll move on to Dr. Toke regarding what's the role of ultra deep next generation sequencing of plasma cell free DNA in patients with advanced lung cancer. Toke, you are muted. Unmute yourself.
Yes, sir.
Yeah. The question is, what is the role of ultra deep next generation sequencing of plasma cell free DNA in patients with advanced lung cancer?
Yes, sir. I got it. This is along with this clonal hematopoiesis filtering. It will help to detection of targetable oncogenic drivers, as well as it will be useful in the diagnosing or studying this chemotherapy drug resistance in non-small cell carcinoma when there is no enough sample or no enough tissue sample. When there is a tissue is the issue, and that is not a good amount of tissues. If not available for this genotyping. Then this ultra deep plasma NGS has role along with clonal hematopoiesis.
Thank you. Right. Thank you. Thank you. So there is a role of ultra deep next generation sequencing in the case of advanced lung cancer. Thank you. So I request Dr. Sanjay Sahay sir that can you throw some light on the tumor biopsy and liquid biopsy? Already you said that tumor biopsy is invasive procedures through bronchoscope or CT guided, and the liquid biopsy is a non-invasive test. Can you throw more light on this tumor biopsy and liquid biopsy?
Yeah, as you said earlier, tissue is the main issue. So from the tumor biopsy, it is good for a pathological point of view, but from the patient point of view, or sometimes they don't agree for the, suppose we don't get the right amount of tissue or the tissue is not enough, then in that conditions, it is really difficult for the for the proper diagnosis of the patients. Multiple sampling of the tissue from the chest by the bronchoscopy. Sometimes patients they don't agree to that also, repeated bronchoscopy. So by tumor biopsy, although it is very important for the histological diagnosis of the confirmation of the patients, also it can tell us about what stage the patient is in. So staging of the cancer can be diagnosed with the help of this tumor biopsy. However, liquid biopsy, we can get the sample from the blood. You can get the sample, and we can replicate that. So repetitions of the sampling is not required, as in cases of histopathological examinations or from the tumor biopsy. No need to invade the patients. This is a non-invasive technique. It can be done in the lab, and so it is easier for the patients also, although expensive, but it is easier for the patients, and the patients also helps. Although I must say that this histological diagnosis of the tumor biopsy is the gold standard still, though there are increasing trend for all the persons. If we have got the facilities, as doctor said, this liquid biopsy is going to help much, but in the longer run. But as of now, this liquid biopsy has not replaced the histopathological. If the histopathological sample is there, so it will help for the early for the best diagnosis of the treatment. Serial evaluations in case of this histopath. Suppose we have removed a patient, resection of the lung has been done, or the tumor has been resected. So serial evaluation cannot be possible in those cases. However, it can be done from the blood sample of the patient using the liquid biopsy. So there are advantages of the liquid biopsy over the tumor biopsy. However, it has not replaced the tumor biopsy or the histopathological examination from the tissues till date. But in the near future, I feel that it will be helpful for all of us to early diagnosis, quick diagnosis, and we can also see the progress of the disease and the response to the treatment as well as. So definitely liquid biopsy is coming up, but till now, yes, we have to wait and watch. I think all the treating physicians and the oncologists, they agree that this is really less amount of tissue is difficult for the pathologist as well as for the treating persons also. And once we do FNAC or we can do the tissue biopsy, sometimes very little amount of tissue that is difficult from our part, we don't get it. And a few days back, when we are doing from the posterior part of the tissue, the lung tumor, it was just attached to the bone posteriorly. So very difficult to reach there, even in the ultrasound guided and so too. However, we managed it and it came out to be non-small cell, but it was failed in some other institute. So really difficult task sometimes. So this is how it helps.
Thank you, Sanjay sir, for the wonderful answer. Tumor biopsy. As of now, this is the current diagnostic modalities when compared to liquid biopsy. It's coming up in a rapid way, but still the gold standard is the tumor biopsy for the proper histopathological diagnosis. Yes, correct. So over to Dr. Sharada ma'am. Regarding how do you triage the cytology samples for diagnosis and molecular testing?
So usually it is the tissue biopsy, which is the preferred method for doing the molecular testing samples. Having said that, even the cytology samples also can be triaged for molecular samples. So these can be either direct smears or needle rinses or liquid-based cytology samples. So direct smears, in case where the aspirate is, the EBUS TBNA aspirate is directly, it is expressed onto the slide and a direct smear is made, these smears can be either air-dried smears or alcohol-fixed smears, and both air-dried and alcohol-fixed smears are stained properly with the appropriate stains, and then after the diagnosis, the material can be scraped from those smears and they can be used for molecular testing. That is one way, using the direct smears. The other one is after the ABS TBNA aspirate is smeared, is expressed onto the glass slide, a part of that material can be still left out in the needle. So that needle can be rinsed in a solution, in a normal saline, and that can be either made into a cell block or it can be made into a cytospin preparation. The cell block means the formalin fixed paraffin embedded block. So that can be used for molecular testing. And even the cytospin preparation, once the slide is made, diagnosis is made, and that can also be scraped. The material also can be scraped and used for molecular testing. So these two, then the third is the liquid-based cytology samples, where the aspirate is put into a tube containing a preservative solution like cytolite, and this can be again used for either thin prep or sure path, and slides are made, smears are made. Again, once the diagnosis is made, the material can be scraped and used for molecular testing. So these are all the ways in which a cytology sample. So these samples can be not only the EBUS TBNA aspirate, can be either even bowel samples or sputum samples. So all these samples can be triaged and can be used for molecular testing. Having said that, this has to be performed only in a properly validated lab.
Thank you, madam. Thank you for the valid points for the clinicians. This is all very, very useful clinical practice. Thank you, madam. So over to Dr. Venkat, sir. The question is, at recurrence, do you repeat biopsy? So how would that help?
Yes, sir. Exactly. So suppose we are treating a metastatic lung cancer, and we have started with first or second generation TKIs along with chemo or osimertinib, which is third generation TKI, and after 1 to 2 years, patient had progressing symptoms, again recurrence, some lung mets or bone mets, which is causing symptoms and all. So at that point of time, the patient would have developed some resistance mechanism. So unless we know what resistance has developed, we cannot target again. So if patient had EGFR mutation and we started TKIs, when we do a repeat biopsy, there could be resistant mutation like T790M. So earlier osimertinib was used for T790M. Now we are using first line, but we have not used, if T790M mutation develops, we use osimertinib second line. Similarly, there could be C737S mutation, which is a newer mutation, which is again resistance mechanism. Then there could be a small cell transformation in certain cases. Then we go to switch to chemotherapy. In certain cases, there could be MET exon 14 skip mutation. So we have anti-MET targeting drugs like tepemetinib, capmatinib, etc. So that would definitely help in identifying that. But again, the problem is if bone mets are there, from bone mets when we get the tissue, again it has to be demineralized and all. So sometimes NGS may be challenging in that situation. Our patient may not agree for a second biopsy. So we have to counsel the patient that this is having an implication change in treatment paradigm. So at that point of time, and one more issue is when suppose we have treated patient for 2-3 years and patient has complete response, complete clinical response on PET-CT, there is no disease. Patient may ask how long I have to continue with the side effects of whatever side effects that are there with TKI or immunotherapy and all. So can we stop at that point of time in metastatic setting? There is no clear-cut answer for that. But in circulating tumor DNA or liquid biopsies, if we have been tracking serially, and initially there were few cells, 5 cells or 10 cells in circulating tumor DNA, now they have become 0. So in that case, we can offer to monitor that and keep doing PET scans to see if there is any recurrence, again start treatment. So, but the problem is circulating cells and all are still not validated enough, and they are quite expensive. Like the standard ones, which are done by Guardant, and foundation ones cost about 3 lakhs. So serially doing that kind of test is impossible. Indian labs are doing, they are offering, but we need a lot of more data and validation and all to trust them and to get to make our treatment decisions based on that. Thank you, sir.
Thank you very much for this wonderful answers for this. Sometimes some clinical scenario warrants this kind of repeat biopsy for the again what kind of targeted therapy we are going to offer to the patient. This is an important. Okay, thank you. Dr. Toke, can you throw some light on the role of immunotherapy in the cancer treatment according to the NGS report?
Yeah. There is a lot of innovation as well as researches and a lot of clinical trials are going on currently everywhere in the world as well as in India also regarding this role of immunotherapy. But as far as just I am not going to detail of this immunotherapy as far as NGS sequencing. There should be the proper and ethical selection of the patient for this therapy, and there are 3 aims of this therapy. This immunotherapy will ask body to recognize the cancer cell as a foreign one, and they should react against those cells. That is one of the first aim of this immunotherapy. Second one is it will stimulate the immunoresponsiveness of the body to fight against those foreign as well as these cancer cells, what we call. And third one is the relieve the inhibition of the immune system that allows tolerance of the tumor growth to the body. So these are the 3 aims of the immunotherapy, and targeted or ethical selection of the patients for the immunotherapy, as it is very much costly as far as Indian continent is present. So there should be the ethical recognition or ethical identification of the patients for the immunotherapy. Not each and every patient of the lung CA should be placed on the immunotherapy, and just wastage of the, what you can say, the resources in the Indian continent.
Yeah, thank you. So regarding financial constraints, so countries like India, so we have to see very carefully, but there is a role of immunotherapy in a cancer treatment. But there are certain, we have to see the hurdles and go about it. Individualized treatment is very, very essential. Thank you. But Sanjay sir, there is one practical question to you regarding in your center. What's your experience in your center? Do you have a preference in biopsy like forceps biopsy or cryobiopsy? In the pathological department, what do you feel? So what is the recommendation, guidelines in your department? Yes, sir. Forceps biopsy or cryobiopsy? What is your center experience?
The cryobiopsy definitely has got an edge over the forceps biopsy. There is no doubt about that. They provide good amount of the tissue. They freeze the suppose actually it is done when there is a larger suppose tissue is involved. You want more of the tissue, or if the diffuse lung lesions are there, so definitely it is going to help. So and in case of sometimes our mediastinal lesions are there, so cryobiopsy is helpful. We get good amount of tissues, but at the same time in my center the problem is again it's a private institute, and asking the patient for cryobiopsy over the normal forceps biopsy is definitely one has to think about the patient's conditions also, whether they'll be able to afford it or not. It is expensive. Cryobiopsy is expensive, although they get a good amount of result. Yield is high, but and the tissues by histopathological or through the forceps biopsy, what we call it, we get limited amount of tissue. Here we get large amount of tissue. So the yield is definitely less in the forceps biopsy than that of the cryobiopsy. And for patient point of view, if they are able to and they are ready to afford it, obviously the cryobiopsy will be helpful. Although chances of getting bleeding and pneumothorax is more with the cryobiopsy and less with the this forceps biopsy. We have been trained initially with the help of the forceps biopsy starting. We are taking it. Most of the times, if you can see the lesions also, and if the lesions is through the bronchoscope also, you can do the forceps biopsy and take out the tissue. And if the tissue is good enough, we get the proper result also with the help of the pathology. So cryobiopsy, of course, is helpful. But if the diffuse lesions are there, like ILDR is there, and we want to differentiate it, then it is obviously helpful. Otherwise, we can also rely on the forceps biopsy simply, and a good amount of tissue can be taken from them.
Thank you, Sanjay sir. Coming to Sharada ma'am, already you presented in your presentation beautifully about all the details. Again, for the late joiners, I'm asking this question. What are the different protocols followed in a lab which help in optimization of the tissue? Over to Sharada.
So, as I've already said, these lung cancer biopsy samples, the primary purpose of these samples is biomarker testing. So, these are molecular priority samples. So, the major goal of these molecular priority samples is preservation of the tissue for molecular testing. So, we pathologists follow certain protocols to optimize the tissue and preserve the tissue for molecular testing. So that starts from sample handling, then sample processing, and then sample reporting. So coming to sample handling. So as soon as we receive this lung biopsy, what we do is in most of the labs, we use certain color cassettes. Suppose if that particular center uses blue for lung cancer samples, all the lung cancer samples will be placed in that particular only blue colored cassettes. So why we do this is when these cassettes go to the histotechnologist, the technician will know that these are lung biopsy samples and he should be very careful while trimming the tissue. So that is one thing. Next, sample handling. Sample handling, here there is a major role of the histotechnician. So what the histotechnician does is he does only the paraffin block is only superficially sectioned. Only superficial sectioning of the block is done. This is again to preserve the tissue. So most of the diagnosis can be made even if there is 50% of the tissue. So superficial sectioning of the tissue is done. And even another thing is multiple sections for both H&E and immunohistochemistry are taken in one setting. So this is again to prevent the loss of tissue while refacing the block. So in one setting, multiple sections are taken for H&E as well as immunohistochemistry. Then another practice that we follow is, the technician follows is, whatever the tissue in between the sectioning, whatever tissue is there, even that tissue is also captured. Instead of discarding that sample, even that tissue is also captured and stored suppose in case it is required for molecular testing, that tissue also can be used. So that is for the role of the histotechnician. Then comes the sample reporting, the role of the pathologist. So the pathologist, as I've already said, should be able to make the diagnosis on H&E stain. If so, morphologically, if it is an adenocarcinoma, give it as adenocarcinoma, or if it is morphologically squamous cell carcinoma, give it as squamous cell carcinoma. If it is small cell carcinoma, give it as small cell carcinoma. Suppose if the pathologist is not able to identify it as adeno or squamous, not able to subtype it, and if it is a poorly differentiated carcinoma, only then the pathologist should do the immunohistochemistry markers. And that too, the guidelines say that only limited IHC panel has to be used. P40 for squamous cell carcinoma, TTF1 for adenocarcinomas. Suppose if they are not able to classify it based on these markers, then one more marker based on the center experience, another marker can be used. So this is again to all these practices are to optimize the tissue for molecular testing.
Thank you, Sharada ma'am. Pathologist perspective, there are a lot of protocols we have to follow in the lab, pathology lab. So for optimization and the diagnostic accuracy, we have to do a lot of so we have to follow the protocol. Thank you. Over to Dr. Venkat sir. How is the integrating targeting therapies impacting the prognosis and survival in advanced lung cancer?
Yes, sir. Actually, in the past 15 years of my experience from my resident days, what I have seen in lung cancer is like in initial days, it was like 6 months to 1 year survival was there in metastatic settings. But now we are seeing patients beyond 3 years, 4 years, 5 years. Even if we want to give a patient's attendance and they are not giving up and they want newer treatments to go on. Some patients have used 7 lines, 8 lines, and beyond 10 lines also. So the survivals have tremendously improved. And suppose if we see EGFR mutations, now we have beyond the TKIs, the combination of the power of chemo and precision of targeted therapy in the form of in EGFR mutated patients who have progressed, there is amivantamab plus lazertinib, where it's a bispecific antibody targeting both EGFR and MET, as well as lazertinib is a newer TKI. Again, there is datopotamab deruxtecan, where we are targeting. Deruxtecan is a vehicle deruxtecan is the chemotherapy, which is usually microtubule inhibitor, which is specifically delivered to the tumor site. That is datopotamab, which targets the receptor. Like receptor could be TROP1, TROP2, Nectin, then HER2, HER3, EGFR, MET. So because of these newer drugs, antibody drug conjugates, bispecific antibodies and all, the survivals have tremendously improved, and there is a lot of research going on. Even CAR T cells are now emerging in solid malignancies also. wherein chimeric antigen receptor T cells are developed, which are actually from the patient's T cells only, are isolated and they are amplified and they are again given back to the patient following high dose chemotherapy. So that is being also explored in patients. And after target therapies are explored, we have immunotherapy now in patients who don't have any targets or any driver mutations. That is around 40 to 50% of patients. Immunotherapy can be integrated along with chemotherapy and survivals are doubling. The beauty of the immunotherapy is that around 100 patients if we treat, 30 to 40% patients who get response, that is for long time, quite long time. It is like a plateau, the curve is plateau, the survival is prolonged to a quite extent. The rest of the patients probably need trials and all. So immunotherapy cost also is coming down significantly compared to earlier. Now Indian molecules are also going to be launched, Indian generics. So that would bring the price down significantly. And even the original innovators also are giving a lot of patient support programs and all. So by integrating targeted therapy, we are definitely prolonging survival to the order of, we are looking to beyond 5 years now, survivals. So that's it.
Thank you. So a lot of advancement happening in all the field, mainly the oncology. When I compare to the last decade, so this decade has a tremendous improvement in targeted therapy, and this is a multimodality treatment. The survival prognosis is also very good with this latest advanced targeted therapies and immunotherapy and all. Thank you, sir. There is an announcement from our CCI founder, Krishnaji, regarding today's login. So far, 1,355 logins in this webinar. Thank you all the delegates. Any questions you can post, we'll address appropriately. So thank you, and we'll move on to Dr. SK Toke. The question is, next generation sequencing and all we are talking. So is NGS cost effective in Indian settings? So Western world, okay, no problem, everything is insurance covered, that and all. But here, Indian perspective, so what is your take on this? Is NGS cost effective in Indian settings?
Yeah, NGS is cost effective. Initially, its cost was around 20,000 to 30,000 for all the NGS that panel, which was including all the gene mutations and all. Why it is very much important? Because it has central role in clinical decision making as far as lung CA treatment is concerned. Optimization of diagnostic procedures, at least for the two reasons. Because recently this mutation driven treatments for the lung CA has been steadily increasing throughout the world as well as throughout the India also. And another factor for this thing is that tumor agonist treatment that depend on the molecular alterations has been recently approved by the FDA. So that effect is also going to change this use of this NGS, because if you are going to do single gene genomic testing, it will cost minimum 4,000 to 5,000. Again, it will take time, same as this NGS. So there is a lot of wastage of time also, and money will be little. If that is negative, we have to go for the another genome testing. That will again cost 4,000 to 5,000. So that cost again will go very high if we are not doing the diagnosis. But by using this NGS straightforward, or you can say upfront, if we are going to use this NGS, we are going to get that results in 10 to 15 days. And we will come to the conclusion, and according to that, we can start this treatment of the lung CA, and that will help the patients for the further prognosis as well as you can say relief from the cancer.
Yeah, thank you. So NGS, so role of NGS is very, very important thing, but at the same time, we have to do some financial constraints and other insurance coverage and all. So we have to take into consideration for the Indian populations. Yes, of course, correct. So move on to Dr. Sanjay Sahay. There is, can you throw some light on the racial and genetic disparity in lung cancer, incidence, prevalence, whichever the thing. So can you throw some light on that?
The racial expressions or the disparities in the lung cancer is important in the sense that blacks, actually usually when we divide it is either in the black, African ancestrally and the European ancestrally, and some Asian group. So African ancestrally blacks are more vulnerable for the lung cancer, and they usually present with the serious type of the lung cancer. So mortality is higher in them. However, and smokers, however, it has been seen that blacks they get more of the adenocarcinoma than that of the white. If you come to the and similarly the different genes which we discussed earlier by our other speakers, that the different mutants, EGFR mutants, KRAS mutants, they are also seen in these individuals. And it has been seen that in the Asian population, EGFR mutation is more. It is at least 4 times more than the other populations. And especially if you see, even females are also more vulnerable for the EGFR gene. And it has been seen that EGFR, as I said earlier, it was commonly seen in non-smoker. KRF gene is mostly seen in the smokers, and they have got a high fertility. P53 gene mutations are also there, which is it has got a high fertility rate. So, and heavy smokers, they are more likely to have KRS P53 mutations. Young individuals who are non-smokers, they are likely to have EGFR mutations. So identification of these individuals, that whether they are black or they are from the European ancestry, and we can assume that which type of and from the history, that whether they are smokers, heavy smokers, or they are non-smokers or ex-smokers. So accordingly, we can think that patient might be having this particular type of mutant in them, and so that treatment modalities can be planned out accordingly. So this is important, that we must know about the epidemiology of the disease process, also which group of the patients are more vulnerable and how much is the mortality. So this is how the genetic and racial disparity plays a role in case of lung cancer.
Thank you, sir, for the wonderful explanation for this racial and genetic disparity, the incidence prevalence, and how to impact on the diagnosis and treatment modalities. Thank you. So over to Dr. Sharada ma'am, regarding what are the different biomarker testing platforms available as of now, currently? Yes, ma'am.
There are various biomarker testing platforms, and these include single nucleotide assays and comprehensive molecular profiling. In the single nucleotide assays, we have the PCR-based assays, FISH, and immunohistochemistry. And in the comprehensive molecular profiling, we have the next-gen sequencing. So in single nucleotide assays, in single gene assays, what happens is there is already a pre-designed primers, and these pre-designed primers, they target only 1 to 2 already known sites in the predefined gene. And comprehensive molecular testing like NGS, so they can target multiple targets in multiple genes in multiple patients simultaneously. So there is simultaneous analysis of multiple genetic alterations in case of next-gen sequencing. Like it can be either SNVs, like a single nucleotide variants, or copy number variants, or deletions or insertions, or comprehensive or complex genomic alterations. So all these can be tested in NGS. Another thing is NGS is cost effective. The tissue can be optimized in NGS, and it is cost effective. And in many of the labs, the turnaround time has also come down to 5 to 8 days. So when compared to both has their own advantages and disadvantages. But if the patient can afford, it is a comprehensive molecular form. That is, NGS is recommended over the single gene assays.
Thank you, madam. Thank you very much for this wonderful explanation for this question. So move on to Dr. Venkat Sampath regarding what are the newer treatment avenues being explored in targetable lung cancer with the driver mutations?
There has been a lot of research going on, sir. So as I mentioned, most of the times, first line, second line, we have good options. Down from third line and all, when the resistance mechanisms develop, we look for newer options. Like now we are seeing certain enzymes like folate alpha reductase inhibitors. Like now a drug has already been approved. All these things are happening at such a rapid pace that every 3 months, 2 months, new molecules are coming into market, and we have to again study them, and we have to explain the patients, and these will be expensive, and patients are ready to import also in certain situations. So in folate alpha reductase inhibitors, again, this is an antibody drug conjugate, sacituzumab vedotin. Then in patients in whom there is MET pathways, we have again telekistamab vedotin, as well as tecomatinib, capmatinib, etc. Again, in some patients, new molecule, a new target called ITGB6, This is also quite latest, like last 1-2 months these molecules have come. So in that situation also we have a target in HER2 mutations. Then zogratinib has been approved yesterday actually. So many new molecules are there and available, and the thing is, all of them cumulatively increase 5 to 6 months of progression-free survival. So overall survival is crossing beyond 3-4 years. So in targetable mutations, suppose ALK fusion is there. In that case, we have earlier what used to happen with first generation ALK mutations treatment targeted TKIs like crizotinib and ceritinib. Most of the times, the tumor would have got good response, but however, because these drugs can't cross the blood-brain barrier, there would be brain mets down the line. So now the newer drugs can penetrate the blood-brain barrier because these are quite small and they are having that penetrance equivalent to that peripheral circulation, such as alectinib and lorlatinib. They have improved CNS-free survival or brain metastasis-free survival. Similarly, in patients who have MEK pathway, we can target using bimetinib, selmetinib, etc. So other drugs in the Notch mutation area, PA3K, AKT, mTOR pathway. So all the pathways can be explored because these are all downstream to EGFR ALK and all. So when the upstream EGFR ALK mutation treatments fail, some resistance develops downstream. So that could be targeted. Next line, and that is what is happening in translational medicine and research. So which will keep on providing multiple molecules in the pipeline. Thank you.
Thank you, Venkat. There's a lot of advancement happening. Every once in 2 months there are new molecules coming up for the advancement treatment modalities of individualized and personalized treatment basis. So we have a lot of treatment modalities and now a lot of diagnostic modalities also. So thank you. We had a wonderful discussion on the pathology and precision in diagnostics. So we'll almost we come to the end of the sessions. May I request every panelist with a very good explanation for each and every questions. I learned so many things. I hope delegates also learned so many things about the latest advancement happening in the field of pathological diagnosis and oncological treatment and clinical perspective. So we had a wonderful discussion. May I request all the panelists, can you give just 1 minute or take messages for the delegates. Over to Dr. Toke, you start with you. Give a final take a message from your side as a pulmonologist, clinician.
My final takeaway is this one, sir. Actually, there should be judicious use of all these chemotherapeutic drugs, and there should be some cost reduction as far as this Indian continent is concerned. Indian continent is considered because of this developing country and low economical strata of this Indian people, and nobody should strive the treatment because of the low economicity or low financial status. Everybody should get the treatment as per whatever is the criteria for that.
Yes, okay, thank you. So we're all a developing country. We are facing a lot of hurdles in the management health system. So one of the highest populated country in the world is India. So number one, highest populated country. We are facing a lot of struggles in health treatment wise. So if there is insurance coverages for all the these kind of targeted therapies and all, because cancer incidence day by day is increasing. And among that, lung cancer. So 1/3 only, we can pick up an early. Majority, 70 to 80% patients presented with advanced malignancy, advanced cancers, only the palliative and targeted therapy. But nowadays, we have a treatment for every stage. So including palliative therapy, and there are a lot of oral treatments available for that. But one thing is financial aspect. So thank you. That we'll have to consider that. So, Dr. Sanjay Sahay, sir, you take a message from this point of the discussion.
It was a wonderful discussion. We also got to learn so many things. But what my suggestion is, there should be a good coordination between the pathologist and the clinician, so that we'll help, and he or she can help us to reach to a particular diagnosis, and we try to save the patients as early as possible. And similarly, the newer modalities and the biomarkers. If we have got good facilities to identify the early cancer development with the help of biomarkers, then it will be helpful for patients as well as for us also to treat the number of the patients, and by that we can decrease the mortality associated with that. So early diagnosis and with the good rapport with the pathologist will help for the diagnosis of the patient. Sometimes what happens, we send the sample, pathologists were not convinced that the sample is not good enough. But at that time, we also get bugged sometimes. What is this? We get so much trouble in getting the sample, and we are not getting it. As a clinician, I'm saying this is what is happening. So we must also understand their problem, and they should also understand our problem, that how the things can be done in a proper way, so that the benefits can be transmitted to the patient in a proper way.
Thank you, sir. So we have to have the multidisciplinary discussions with the tumor board, which consists of the pulmonology, radiology, pathologists, and oncologists sit together. And based on the cell type and the driver mutations, we have to know properly plan the treatment modalities. So plan A or plan B, you have to tell the patient attenders such a way that these treatment modalities based on a lot of factors. Patient comorbid condition, financial status, and insurance, so many things plays a role in the diagnosis and treatment for the cancer. Mainly the lung cancer is very difficult cancer to diagnose and treat. So 1/3 they present with the direct symptom of lung symptom. So 1/3 is silently to be there. So routine checkup we picked up there is a mass in the lung. So then biopsy which shows or squamous, whatever, small cell, non-small cell. Then we submit for the tumor board and for the treatment purposes with the surgery or radiotherapy or chemotherapy or biotherapy. There are so many treatment modalities. So thank you. Over to Dr. Sharada ma'am for your take-home messages for this audience. Yes, ma'am.
So I would like to re-emphasize on the same points. One for the clinicians, the pulmonologists and thoracic surgeons, and the second for the pathologists. So to the clinicians, please provide all the information, the clinical information as well as the radiology information which is required for the pathologist on the TRF form. And if the biopsy is done for any other indication, like the case scenario that I've shown, please communicate to the pathologist. And for the pathologist, what I would say, I would like to emphasize on the same point that please remember that these are molecular priority samples and preservation of the tissue is very much required for molecular testing. And please don't exhaust the tissue by doing a panel of immunohistochemistry markers. And suppose if you suspect a metastatic carcinoma, please correlate, talk to the clinician, get the history, and even in that case, do only the relevant IHC markers. So this is what I would like to.
Thank you, ma'am. Thank you, ma'am. Communication and the interdepartmental discussions are very, very important for the arriving at quick diagnosis, correct diagnosis for the oncologist treat easily. So without any time delay, turnaround time, etc. So thank you very much, Sharada ma'am. Over to Dr. Venkat Sampath for your final take-home messages for this audience. Yes, sir.
So this is an era of personal medicine. So every patient has to be classified molecularly, and molecular classification is important with a multidisciplinary approach with support from pulmonology, pathology, nuclear medicine, radiology, and surgical, medical, and radiation oncology. We would have to tailor a perfect plan for the patient's treatment, and we have to follow the guidelines, and guidelines have to integrate all the information regarding the molecular subtyping. Then in patients who don't have target driving mutations, the immunotherapy options, and as other colleagues have said, optimizing and judiciously using the treatments and not unnecessarily burdening the patient is crucial. See, the overall purpose of all our discussions is to do the best justice to the patient, improve his quality of life, survival, and all. And as sir has already said, early diagnosis is quite important. So we have to probably find out new screening methods, because though low-dose CT is helping, but still many of the patients are presenting now in the age of second and third decade. 20 to 30 to 40 patients we are seeing with advanced stages. So that should not happen. Probably we have to work on screening methods. Thank you.
Thank you very much for wonderful take-home messages from all the panelists. So I conclude my talk and take-home messages. So today's discussion, we learn a lot of things. So early diagnosis is important. So India is a developing country. So we have a lot of TB burden. TB burden is there. One of the differential diagnosis of any case with hemoptysis, first diagnosis, of course, tuberculosis. But second diagnosis, we have to think in terms of malignancy. Lung cancer is a common thing. Only thing is an underdiagnosis. Clinical perspective, so we have to rule out TB or malignancy. This is dilemma is going on for the general physician point of view. So we have to rule out particularly, so whether no, this is a TB or malignancy. For that, sputum microscopy and sputum cytology are one of the important tools to start with. If you have any negative thing like gene expert negative for tuberculosis, so we have to utilize the pulmonologist, interventional pulmonologist for the bronchoscopy and lavage to rule out lung infection like tuberculosis or it's just a malignancy. And any endobronchial lesions, we have to biopsy and sampling are very important. Proper acquisition sample and sent to the culture as well as the histopathology examinations are very, very important. So how to procure specimens and all, our today's discussion, we have a lot of learned points. So we are all practicing in an era of precision medicine. There is no empirical entity. If any dilemma, so refer the patient, feel free to refer the patients to appropriate consultant. So pulmonologists for the tissue diagnosis and radiologists for the peripheral lesions. Nowadays we have a lot of advancements to navigating bronchoscope. Everything is available to take the peripheral lung lesions. So we need to have the proper diagnostic modalities and investigative tools and proper referral. So avoid unnecessary empirical medications. So tissue is the issue. So precision medicine plays a major role to avoid unnecessary morbidity and mortality. So there are a lot of advancements happening in the field of oncology. Every field, but oncology is a very rapidly, fastly growing field, and a lot of pathological markers, immunohistochemistry and molecular diagnostics, a lot of driver mutation testing, and a lot of panel, NGS panel, heart panel. There are plenty of things. Day by day is advancement happening. So we have to keep learning. So the Chest Council of India, CCI, is doing a yeoman service to our doctor community for updating, upskilling our knowledge, fine-tuning the way. So I thank you once again, our Chest Council of India founder, N.S. Krishna sir, Narayan Pradeep, and our President, Ashish Dubey, and Secretary Anil Maske, webinar coordinator, Dr. Vijaykumar Chennam Chetty, Dr. Shivani Swami, Kirat Ma'am, Ravi Dosi, and Atri Gangapati, for all the leaders of Chest Council of India doing a tremendous human service for the healthcare, mainly the respiratory care, so and multi-allied sciences. So thank you, Sharada ma'am, for a wonderful participation. You are all the world-renowned thoracic pathologist. Venkat Sampath, you are all practicing in a very great center, Apollo Hospital, very high-volume center in India, high-tech city. So Toke, you are from Pune, wonderful. That's Sanjay, Sahay, beautiful presentation. Like you told about a lot of things, liquid biopsy, and the a lot of NGS. So many things we have learned. So many things. I think delegates. Or definitely they will benefit from our today's discussion. So any questions? If there are no questions, so with that we conclude this talk. Any questions? Please check technical team. So almost we have answered. This is straightforward. Everything very clear-cut guidelines, recommendations. So we have to follow strictly as per the guidelines. So we need to have a lot of Indian guidelines for the, a lot of pathologist perspective, oncologist perspective and all. So we need a lot of research and investigations. So with that, I thank you all for the wonderful, participation and discussion. Thank you, delegates. Thank you, technical team. Thank you, sponsors, Lupin. So wonderful discussion. We'll meet again next Thursday with a different topic. So next week we have our CCI Con, Kolkata. Welcome to join this fantastic 3 days conference. So long live CCI. Thank you very much.
Thank you. Good night.
Thank you.
Thank you all.
Thank you, Dr. Jayaraman, for this wonderful arranging this meeting. Thank you very much.
Thank you all.